reports of the Mental Health Taskforce. For those of you who might be joining us for the first time, you will recall that last year at Narok, the president spoke passionately about the challenges that have befallen our country with respect to the increasing problem on related to mental health. Again, you will recall that he directed the Ministry of Health, together with other related ministries, to very quickly get into action and investigate and report on the challenge of mental health in the Republic of Kenya. Subsequently, Cabinet met, deliberated on the matter, and directed that a task force be formed to evaluate this particular challenge. The task force subsequently did its work, visited many counties and talked to various groups of wananchi, received written memoranda, held various public hearings, and it satisfied itself that it had collected the views and opinions of the people of Kenya on the subject at hand. Subsequent to that, the task force retreated, wrote its report, and last month submitted its report to government. This series of webinars is intended to increase the awareness of the true holders, stakeholders of this report, which is you, the participants today, as we continue to inform you and discuss with yourselves those very, very key findings. Now, today we have a distinguished panel of experts to take us through the chapter on access to mental health. You have met previously Charity Muturi, who joined the you can see her there smiling, who joined the task force, well, in two capacities. First, to represent Kenyans in general, but also in a special capacity as a user of mental health services. And I hope today she will not forget to tell you a little bit about her personal experience as a consumer of mental health services in our country. So before you talk, Charity, don't spare us, don't spare the people of Kenya. Feel welcome to describe in whatever detail you want the experiences that you have been through as you contacted our services. Then we have a presentation and a video that we will be showing you. It's presented by a member of the task force by the name of Melanie Blake, who is a nurse by training and who runs a very interesting organization called Kamili. And her presentation will really get us into a better understanding of how community mental health services can and are being run in Kenya. We believe this is a very important model because it means that mental health services are, as it were, already reaching the grassroots. After that, we will have a presentation done by a team member on behalf of our very own Professor Atuoli, who you have seen here before, who is himself a member of the task force. Professor Atwoli is not able to join us himself today on account of previous engagement, but his presentation is here with us. To join us towards the end of the afternoon and to answer mostly the very hard questions is our very own Dr. Simon Juguna, who very ably headed the secretariat of the task force and who was instrumental to a large extent in the process of collating, collecting, and putting together this report. I will be available at any point that need arises to make comment on anything that is deemed appropriate by those who do so. Without any further ado, at 15:06, I now welcome Charity. Charity, you look fine. Don't have to correct anything. You're looking wonderful to do your presentation. Go on, Charity. The floor is yours.
All right.
Thank you.
Thank you. So good afternoon, everyone. Thank you for joining us today. As our chair has mentioned, my name is Charity Muturi. I am a person with lived experience with a mental health condition. I am a caregiver to a family member with a similar condition. I serve with Tunawiri CBO, specifically with mental health in the criminal justice system, currently with programs at Madara Hospital Maximum Security Unit and Yatta Prison. And I'm very happy that the task force included us and acknowledged us and allowed us to give our experience and contribute to this process. And so as users of mental health services and caregivers across various conditions, cerebral palsy, autism, ADHD, epilepsy, bipolar, schizophrenia, anxiety, depression, substance use disorders, and dementia, including Alzheimer's, we came together and worked on a presentation by users and users of mental health services and caregivers, and you will find this on page 87 to 89 of the report. I know we have quite a few today who had confirmed that they will be joining, and so I encourage you to read what it is we put together in terms of access to health services, the stigma that we experience, the legal reforms that we need, our challenges and recommendations for education and employment, and even social protection. So you will find that there in more detail. Today I'll be talking more about our experiences in relation to access to mental health services, and part of our contributions are in the actual report. And so I'll be talking about what Kenyans said in my personal experience in access to services, specifically around health workers, we as users of mental health services and caregivers, infrastructure, medication, insurance, and the different things that Kenyans said across the 10 regions. So at this point, I can start the presentation starting with what Kenyans have said. So thank you for joining us. Please feel free to continue asking questions on the chat, even as we start the slides. Okay, so this is access to mental health services, as you will find in the report. What we will do right now are highlights, but you will definitely find more details in the report. So I will start with the medication and insurance. So one of the things that Kenyan said is that medication usually misses a lot in public facilities. And so both at Madara, which is the facility that most people know about, our level 6 hospital, and even in the 26 county hospitals that have a psychiatric unit, Kenyans complain that medication is not available, and when it is available, it is of poor quality, with side effects that reduce compliance. So you have patients who, they really affect them. And I've even listed, personally, I'm not able to afford the drug that I can afford best, which is provided in private facilities and chemists. And when I was creatinine levels dangerously in only 3 months. And so we had to stop it and use others. But even as a patient myself at Madara and even with friends both in public and private facilities, the issue of the drugs provided at our public facilities is very serious. We have drugs that make people zombies and unable to live productively and fruitfully, which is the purpose of this medication. And so there was a huge outcry on the issue of medication, that we even have good medication that's already included in the Kenya medical essential list, but is not being provided. And when we ask even at the hospitals, they say we have olanzapine, but olanzapine is just one, and usually we still have to pay for it. And so there was a huge outcry on that. The second thing that they said is that medication in private facilities is of good quality, yes, but is beyond the reach of many Kenyans in terms of affordability. And so now the problem becomes that what is affordable is what is good for us is too expensive, and what is available is of bad quality. And at any time, these drugs, should be the benefit of the drug should always supersede the side effects. And so we are saying we need to be provided in affordable. Kenyans also talked about, we with mental health conditions, we complained about not being able to afford public health insurance, and especially during this time of COVID, many of us are not able to make our contributions. And even when we have that insurance, it's mostly available on inpatient services. So that means as patients, we will mostly stay until we are very severe so that we can be covered by NHIF. And so it becomes a very reactive system instead of being proactive, because prevention is also providing outpatient services that are available and affordable and accessible for us through insurance. And so we are saying that not only do we need better outpatient cover, but also the issue of cancer and the medication still ties in, because even when I am at the hospital, my family has to bring in medication every week, yet I am covered by NHIF. So you find the out-of-pocket expenses are still there with that insurance and with and so we are saying KEMSA need to up their game, they need to fulfill their mandate. So Kenyans also said that private insurance companies, actually this one needs a whole webinar on its own, because of the retrogressive policies and the evasive nature of private insurance. Because either you will find, like for myself, the first time I was being diagnosed, they said I couldn't be covered because it hadn't been declared. How am I to declare it before it is diagnosed, And then sometimes you'll find that, yes, we cover mental health, but the amount is so limiting that you actually have to, they'll say, yes, we cover counseling, we cover this, but the amount is what now limits what you can get. Because if you go for, 5 sessions of counseling, then the cover ends faster. If you go for medication, especially in the larger hospitals, I remember there's one that only covered me for 4 months because I'd already had an MRI to rule out a brain injury, etc. So there are many retrogressive policies, and Kenyans are angry, very angry. We also had IRA who participated in the, not IRA, sorry, private insurance companies also participated, and they said that for them, usually there is the nature of medical insurance is that they do not really make profit, which we felt is not good enough an excuse, so we are still asking for better care. So there are other areas that Kenyans also talked about. Next slide, please. Infrastructure. This one, you know, the infrastructure was dealt with very, very well. People had a lot to say. And that is the issue of especially our physical infrastructure within our public facilities. And of course, Madara is used as an example because that's what people know more. But what Kenyan said is that these facilities are so bad that they drive stigma, that the actual nature of what we find there reduces even our desire to know why we are unwell or to be treated. So the infrastructure is a big driver of stigma. So that was one complaint. And then Madara Hospital being 100 years old, and we visited as a task force. And we went around the whole hospital, and it is in such bad shape. It's 100 years old. There have been no, renovations. We have buildings that are condemned by the Ministry of Works that are not supposed to be used that are not supposed to be inhabited. And then the same buildings that were there in the colonial era have not been expanded. And so we have overcrowding. Like when I have been admitted, we had about 50 beds, 45 beds and 80 patients. So apart from being condemned and old and inhabitable, they also have double occupancy. And so we even saw that it's not even possible to renovate these buildings unless we just fully destroy them. And we will hear the recommendations from one of the panelists. We also visited the forensic psychiatry unit, and the staff of the forensic psychiatry also participated in the public participation, and the patients at Madara Hospital Maximum Security Unit also had an opportunity to air their views. And so this forensic unit is located in Madara Hospital. It is extremely understaffed. It is extremely disempowering. The buildings are they even look older than in the rest of the hospital, and there are no facilities for rehabilitation or resettlement. And so apart from managing the infrastructure in the rest of the hospital, this one needs to be dealt with. And Madara Hospital also said they struggle with this facility because it has, I think, 30% of the patients in the hospital, yet they receive no funding from it because it's assumed to be a prison, and prison will not receive funding for it. And so they are overstretched in terms of budget, in terms of managing those patients who many of them are there for a long time. Many have been there for decades. And so the issue of, so for the forensic psychiatry unit, we need, there was the complaint of infrastructure, but also, just relooking the whole system because it's not funded and it is a big burden to Madara Hospital itself. Financially. So yes, which is what we've talked about, the funding being a huge burden. And Kenyan said there is need to make services affordable and decentralized. And especially during this COVID season, we've struggled because we have patients who usually come to Madara from other counties, and the issue of barriers was a problem. And like I have a friend who was in her 9th month of pregnancy. They were able to get a letter. They were able to come all the way to Madara. But at Madara, there is no single delivery pack, so they could not admit her, send her back to Nyeri PGH. Nyeri PGH itself, yes, has mental health facilities and has the maternity services, but it is not a well-coordinated system. And even the infrastructure should allow for the 20% of women who suffer mental disorders after pregnancy and childbirth to have a good place to be able to manage both the mother's mental health issues and the child as well. Okay, next slide, please. Okay, so these are some pictures of Madara, which are also in the report. So the one where you're seeing the task force team and the Madara staff, that's actually within the forensic facility. That's how it looks at the moment. We have a few photos on the poor drainage and sanitation, and it's very sad that even the staff do not have their own sanitation. So what is already, terrible for us as patients, what is dehumanizing for us as patients, the staff have to use the same facilities, which is very sad. And they are asking for a total overhaul of what Madara is today to benchmark and also now have the same, in other hospitals, because we are saying we need community health services that are available at the small clinic and dispensary near us, so that there is no facility that has health services and does not have mental health services. There are some slides that, sorry, we skipped at the beginning. There are two different slides for health workers and persons with lived experience. We could go to one of them. The first and second slide. Okay. Before? Yes. So we as persons with lived experience, we participated in the process. We have people who, you know, participated in Eldoret, in Mombasa, and so on, and we were communicating, and it was exciting to see that engagement. And apart from that, we also have the presentation that we worked on, and some of the things we have raised in terms of accessibility of mental health services. The first is the lack of access to available, accessible, and affordable services, including emergency treatment, which is a basic right in the Constitution, Article 43. And so what happens is, even at Madara, we have people who come all the way even from Garissa, they've spent everything they've had as fare, and then they don't have the 10,000 shillings deposit that is needed for the hospital. I have personally seen staff at the hospital contributing so that a patient is able to be admitted. I have seen patients sent back all the way to Garissa because someone would not afford 10,000 shillings. And by the time this person is brought all the way from Garissa, they are in dire need of help. The family has tried to manage up to where it is able to, and they are not able to manage it anymore. So by the time they are bringing this person, they've been on the road even for 3 days. They've been frustrated with this person, and then they have to go back with them. While it is a basic right for us to be able to receive care, and for the government to make some, you know, to make it available or possible for this to happen. And for anyone who's been to Madara on a Tuesday, and it's very unfortunate that Tuesday is the only day that we have outpatient services in a whole level 6 facility, a national facility. All patients in the country are seen on Tuesday. And so you find very long lines. And these long lines, there are those that are in the wards. You may not see how many there are because whichever ward you're tied to is where you go for follow-up treatment. So there are lines in every ward. And then where we have the outpatient, there are huge lines. And these lines are you know, for people to pay the 50 bob for consultation, both for psychiatry, for the lab, for the MCH, for all the services that are in that hospital. So you find that whole line will be like 30% of people who, after lining up the whole day, they are still not able to pay that 10,000 shillings. And so we are saying our rights are being infringed by that, by not providing accessible, affordable, available care. And this should be a burden to the government. And you know, so that's also tied with the issue of insurance, when we were saying that at least if people have free medical cover as persons with mental health conditions, then we would not have issues like that. And it would also encourage people to go as soon as symptoms are seen, because they know they will still be able to receive care on outpatient. Users of mental health services and also and caregivers, we also said we are ignored in policy, because a lot of the times we'll either be called by the media or organizations to give our stories. We do not know what the project is about. We do not know what it is hoping to achieve or how much was received, and we never get any feedback. So we go to TV, we say, my drugs are destroying my kidney. You go to radio, you go to the newspaper, but nothing happens. And so we are saying, in order to be included, because we don't even want a seat on the table. We've been on the menu, but now we want to decide. We are hungry. We want to decide the market that we go to. We want to decide what is the picked in that market. We want to be in the kitchen cooking it. We want to sit at the table when eating, and we want to serve. So that means, at least when we start at the policy level, then we can be able to get to a point where even at Madara Hospital, we are in the board, or in the clinic near us, we are in the board, so that we are able to contribute continuously and our experiences are not wasted. We also talked about the issue of prevention. early intervention or treatment services. There is a huge gap. And of course, because we're also talking of children, we have a lot of mothers who are saying that, you know, they were going from hospital to hospital trying to find out what is wrong with this child. And then they just overhear a doctor somewhere or a nurse talking of Down syndrome. And it's not something they tell them immediately. And at least if this could be done earlier, because every child is monitored in terms of their developmental milestones. And those developmental milestones are the ones that have the red flags that will be able to then say that this child has a developmental delay or a developmental condition or had a heart issue that could be due to the T21 chromosome of Down syndrome, or at least even for us, if prevention also includes when we are going to the, you know, if I have been taken by the police because of loitering, for example, and I stay in that cell for another 3 years, that means there was no prevention and early intervention to say that this person could have a mental health condition and take them somewhere. So we're saying for prevention and early intervention and treatment to be done, a lot of, you know, there was a complaint that we need as a country to embrace mental health so that the Ministry of Health is able to do something about children learning about mental health. The Ministry of Interior is able to see that Nakada is not supposed to be under us, it should be under the Ministry of Health so that they are able to deal with it, and so on. Caregivers gave very moving testimonies during public participation about the emotional burden, the physical burden, the psychological burden, the financial burden, because many caregivers have to forego economic opportunities, because even getting a help who will treat this child with dignity and not harass them is not easy. And so even as a caregiver myself, I have had better systems of care as a patient. But as a caregiver, we are assumed to know what to do. We are blamed. So if a child with autism looks like they are misbehaving, the parent is assumed to not discipline the child. It becomes the fault of the parent. So there is no support from government, no support from communities, no support from our churches, no kind of psychological or financial support. And so that came out very strongly. And even just being able to access therapy services, and especially this time of COVID, caregivers are really struggling emotionally and financially, but there are no support systems for them. So Kenyan said we need this to be dealt with even after hospitalization, both as caregivers and patients. There's a struggle of economic support. So maybe you are able to what is it called? You are able to fundraise and get like 10,000 to get into the ward. Unfortunately, NHIF covers, but you still have to pay for medication and everything that is not available at the hospital. Then, after that whole process, and the nature of mental illness is that in the process, sometimes you lose property, you lose your job, you lose your means of being able to survive, you lose your house, because sometimes people don't realize that these are symptoms, and by the time it is being realized, someone is on the streets or someone is being kicked out of their homes. And then you get out of hospital, and there's no support system. You don't know where to start. So if you had lost your home, your things had been what is it called? Auction, for example, where do you start? And so the challenge of social issues, including employment, blah, 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 or economic issues, and not being able to deal with that, push us again into a relapse, and we end up back into the system. So we find the health system is trying to cure or treat, not cure, treat an economic problem. And so there was a huge outcry that mental health is not just within the hospital. When we walk out of that hospital, we need facilities, we need psychological support, even if it's having support groups within hospitals for patients separately and caregivers separately, to be able to deal with these issues better, but also to be referred to the Ministry of Social Protection and actually find support there, because the Ministry of Social Protection has prioritized physical disabilities. And so, All of us under developmental, intellectual, psychosocial, and cognitive and neurodiverse disabilities under the UN Convention of the Rights of Persons with Disabilities are still not prioritized by the Ministry of Social Protection. And they also do not understand temporary disability, because sometimes someone can be, the worst of this illness can be, like for 10 years, and after that they are better. So what caregivers were saying is that we need something to be done beyond the hospital to be able to provide social protection and economic protection. Psychology services. They are unavailable in public facilities. They are too expensive in private facilities. And the nature of psychology is that you would have probably 5 to 10 sessions for you to complete a process. And for me, there are times I've opened wounds and then I'm not able to afford to go and deal with them. And so I'm surprised I find I'm in a worse place than when I started, because we unpeel an onion slowly to deal with this issue on top, and slowly it goes inside, and that takes several sessions. However, not being able to afford it out of pocket, not being able to afford it even through private insurance, because they'll say they cover, but you'll find, in fact, as a patient, it's very sad that you'd actually sit and look at this cover is this much, my medication is this much, this times 12 months is this much. So this medication actually will cover me for 8 months and the rest is not there. And that is for the person who's lucky to have a private insurance. So we are saying the only way we will be able to afford psychology services is if we have psychologists hired or human as part of the human resource. And so even personally, after I was unable to afford private care, I started at Madara. It was 500 shillings, which is very affordable, because then the government is meeting the huge chunk of the cost. And then it's no longer available because they had one psychologist, one for a whole level 6 facility, and there are none in the counties. But psychologists were able to speak. Maybe next slide.
Charity, I think we're coming to the end of this. This is a fascinating presentation. But I think we have 2 other presentations to go on to. I'm not cutting you, but I'm just
okay.
Proceed, please. Yes.
All right. So in a minute, so healthcare workers said there is limited human resource. We need more professionals, and some examples are that Mombasa County has 1 retired psychiatrist on contract, no psychologists at Madara Hospital or in the counties. They also complained that their training, the training of nurses and clinical officers, who are the ones who treat the majority of people at primary level healthcare, they do not have the training of mental health or mental health conditions to be able to identify and refer. They also said that especially the nurses and doctors, they work in very poor physical and psychological conditions in terms of sanitation, no risk allowance, overworking, and so on. They also talked to, as Kenyans, we said, we have a scarcity of counselors and psychologists in the public service. Yet, nurses said they pay very huge costs to afford mental health training, and then they are taken to an antenatal facility or deployed to other services, or even psychologists. Like we do have a psychologist at Madara Hospital who's employed as a medical social worker. Kenyans from the whole country urged government to ensure training and deployment of multidisciplinary health in our facilities. And also there's poor coordination of mental health care, especially because a lot of us go to traditional healers and faith-based healers thinking that this is a spiritual problem or a curse. And so there's no system to connect the traditional healers and the Ministry of Health so that they can be able to know how to identify what is a mental health problem, how to intervene, how to refer. And one of the things we were saying is even the WHO Mental Health Gap Action Plan is talking about training the very simple people in society who are dealing with many people so that they are able to identify and refer. Thank you.
Oh, Charity, you said thank you. Oh my goodness. Okay, let me say this. I mean, seriously, there are at least 2 reasons that I know you have really delivered on your message. The first reason is that the numbers of participants is increasing rapidly. Usually when a webinar like this, numbers go down, yours are going up, which is a vote. And then secondly, I'm seeing here on the chat, people just are saying, let her continue, let her continue, let her continue.
Maybe I can continue in the answer session.
Yeah, I mean, this is
Answering.
brilliant. Some are saying that you have captured things on the ground. And Njoroge, I think it is. You've captured the situation on the ground extremely well. I'd like to say this very quickly. Anybody who has any doubt about what the task force did and who members of the task force were and how they did the work, I think, Charity, you've done it better than anybody. And I'm really happy and proud that you were there and were able to articulate with as much clarity as you did then and as you've done now. Thank you so much. Don't go away. I'm sure there'll be many questions. Not only have you become an expert in mental health in yourself, you're also an expert because you're a consumer. You see another message. Thank you, Charity, my coffee, like this. Right. We'll now go to the Secretariat and have received a video prepared by another member of the task force, Melanie Blake, who's in charge of this. You see, people are still hearing about you. Ati, well done, Charity. Well done. Makofi again. Yes, that's what I'm reading here. Well done. So, Priscilla, are you giving us the video for Melanie?
Yes,
and
the
numbers
video
are
is
going
being
up.
shared. Yeah.
Sorry? All right, share
the
it.
video is being shared shortly.
Okay, thank you very much. Thank you. It's a very short one, and then you go to Professor Tuole's presentation.
Jambo, habari zenu. My name is Melanie Blake, and I am a mental health nurse, a Kenya-registered psychiatric nurse. And I was honoured and privileged to be asked to work on the President's Taskforce for Mental Health in Kenya. During that time, I was asked to work with the team on access to care. During our time, we were asked to go to various places in the country to listen to what Kenyans had to say about mental health. I was very privileged to be asked to go to Meru and to Nakuru and to Nairobi. And what Kenyans were saying was that our institutions are dehumanizing and they're in a terrible state of disrepair. And of course, that leads to stigma and it drives it. And it was very sad to hear that. They also said that in the communities and in the counties, there was no accessibility to mental health care. Our recommendations are that the way forward is to provide community mental health in hospitals, sub-county hospitals and dispensaries all over the country. But to achieve that, we need to capacity build many nurses, social workers, counselling psychologists and community health workers. All these people would then be able to identify people in the community who were suffering with a mental health issue and refer them to these community clinics for care. And it would be a holistic approach because you would have a psychiatrist visiting monthly with a nurse to assess and review, counselling psychologists to work with the patient and with their families, and social workers to help the families get their patient back into the community and working, and community health workers who know their communities and could go out and find those people who are suffering, who really don't know that there is any mental health care. Currently, if a family has somebody who's suffering from a mental health issue, they often have to be admitted to hospital. As soon as we do that, we're taking them out of their family and putting them in the hospital and taking everything away from them. And you have to rehabilitate somebody like that. If we can manage people in the community and teach their families to care for them, we take that away. This is very important in the future because currently NHIF only pays for inpatient treatment. We desperately need for the NHIF to be for outpatient preventative care to avoid all these people needing to be admitted to hospital. As a result of all this, the Taskforce recommendations are that Madara, which is so old, needs to be rebuilt and refurbished. The county psychiatric wards need to be refurbished so that people feel valued and staff can work in decent facilities to help them to make sure that they look after people properly and lower stigma around mental health. The country needs to adopt community mental health service in every level of healthcare. Mental health awareness and training as part of every medical practitioner's training with an examination. We are trying to raise awareness to everybody. It's not just the medical profession's duty, it is every Kenyan's duty to raise their awareness or find somebody who will help them raise awareness or teach them about it so that they are able to look after their people. Thank you.
Thank you very, very much, Melanie Blake, wherever you are. That was an excellent presentation. Monica, can you clap, clap, clap? Charity, you nailed it for us. Clap, clap, a true reality presentation. Clap, clap, clap. I think, and I'm sure that we'll have similar claps for Melanie, to whom our grateful thanks go. We'll proceed immediately with the final presentation by Professor Atwoli, presented on his behalf by, is it Maureen or Priscilla?
I'll be doing the run through.
Sorry?
I'll be the one doing the presentation.
Okay, go ahead.
Yes,
Proceed.
so Maureen, of course, will project it for us.
Yes. All right, Maureen, let's have the screen. Because I really want us to move on to the discussion because I think there'll be very serious and heavy conversations around this. And even as we wait for a brief comment from Dr. Njuguna, the Director of Mental Health in the Proceed, Priscilla.
Okay, maybe I can, yes. So just 1 minute as we get Prof. Atwoli's.
I mean, if you can, okay, you good to go?
Uh-huh.
I can hear
Just
people
give
whispering
1
all
minute.
over. I mean, just so that we all know, I mean, I think everybody in mental health knows Professor Atwoli, who was until very recently the Dean of the Faculty of Medicine at Moi University in Eldoret. He has recently accepted appointment as the Professor of Psychiatry and Dean at Aga Khan University Hospital here in Nairobi. Yeah, I'm sure that's why he's very busy settling in onto his new job. Priscilla, are you ready to go now that I've introduced Professor Atwoli?
I can give the run through as we wait for the presentation to be shared.
Please do, because time is against you and me and everybody else.
Mm-hmm.
Go ahead.
So, but the beauty is that most of the stuff already been emphasized. organization of mental health services, what gaps we have in infrastructure, which has clearly been addressed by Charity, the Kenyans' view on access.
Priscilla, your connection is not good.
Hear me better now?
Slightly, go ahead.
Okay. So on mental health policy imperatives on access to services, we noted that governments shall ensure that mental health system for service delivery is affordable, it should be equitable, accessible, sustainable, and of good quality. Because what we're discussing is quality access to mental health services. We also urge that the mental health system shall be responsive to meet the population's expectations in dignity and respect. The Organization of Mental Health Services shall adopt the WHO model of service organization's pyramid for an optimal mix of services. And this organization starts from, if you come from the bottom going up, is number one, we should be able to have good self-care as a person. And then moving on to informal community care, primary care, mental health services, which now what we are pushing for, to have decentralization of mental health services to the community services in the primary care in your dispensaries is the first port of call. And then also going up to community mental health services, having psychiatric services in the general hospitals. And on the topmost of the pyramid is long stay facilities and specialist psychiatric services to be offered all over the country. When you look at the cost, of course, when you come to self-care in the lower side of the pyramid will be less expensive. And then as you build up, when you're coming to long stay facilities, then the cost will be higher. But if we're able to have these services in the community, then we're able to make sure that our patients and our clients are able to access the care in a quality way and they're easily available. The gaps in infrastructure, we've already covered the fact that we have facilities that are old. They lack the basic infrastructure needed to deliver, quality services. And we've already seen how the forensic unit at Madara is overcrowded, it's understaffed. So that has already been emphasized upon by Charity, and I will not put in more. But just to note that only 0.7% of level 4 facilities in the country currently provide mental health services. This was not a good percentage to start with. So some of the views that were there was, of course, need to make the Kenya services for the Kenyans accessible. Mental health services for women after pregnancy and childbirth are currently inadequate, as Charity has already said, a story of someone that she saw in the admission from Nyeri. That was really unfortunate. Screening for mental health disorders is actually lacking in the general facilities, as most hospitals also lack mental health services. There was poor investment in mental health service nationally. As you can see, 0.7% of the level 4 facilities provide mental health services. And also the importance of spirituality was emphasized. Something that came out was that political leaders, knowingly or unknowingly, right, would worsen the state of anxiety in the country, because we saw that levels spiked up during pre-election time. And this was something that Kenyans, expressed and would like to be handled. So some of the recommendations that came forth was to adopt community mental health services approach by providing services at the primary healthcare level. No Kenyan seeking mental health services should be left behind. So we are saying we need to increase financing of services and plan to deliver them at all levels of healthcare, from the dispensaries all the way up to the level 6. We also need to enhance human resources for mental health across the country. That means we need to be able to have a psychiatrist on board, we need to have psychologists on board, mental health nurses, we need to have community workers, we need to have everyone working together And that means the government needs to be able to put these people in place in all the facilities across the country. We need to also provide adequate range of medications as recommended in the Kenya Essentials Drug List, because the drug list is there, so that needs to be implemented. There is need to regulate substance use disorder treatment through the medical practitioners and the dentist council. Currently, this is being done by the NACADA. Also, we need to ensure minimum standards of mental health services are met across board so that you can have quality services to all our patients. And I think that's about it for what Prof. Atwali had recommended, and it will be uploaded up. Thank you.
Thank you, Professor Priscilla Macau. That is indeed a professorial presentation. Well done. Right. There are a few questions before we ask. In fact, this is a good entry point to Dr. Jogona's comments. We have a question from a participant by the name of Josiah Osiri, who actually is asking Dr. Jogona, specifically almost, what is the Ministry of Health doing to improve mental health literacy and research in Kenya, number one? Number two, what plans are there to improve the mental health infrastructure in Kenya? And if I may add for Josiah Osiri, what is the mental health policy for Kenya all about? Three questions for you, Dr. Jogona, as you make your comments. Thank you.
So thank you, Chair. Thank you, Priscilla, and thank you, Charity. I think those were very good presentations. I would first by mentioning that access to quality mental health services is the key to us transforming mental health services in this country. And I think this has been one of the major struggle, I can say personally, I have had trying to see that we no longer have the situation as it is now. What does it mean that we have this kind of lack of access, poor quality of services? It means that majority of Kenyans don't access mental health services. And we are talking about more than 85% do not access any form of mental health services. And when I talk about mental health services, I'm looking at it from the holistic point of view, from promotion of mental well-being, preventive interventions to early interventions, because early intervention leads to better outcomes, and also services for people with severe conditions, issues about rehabilitation and habilitations, social protection, and what we call recovery management. And so when all these types of services are not there, what it means is the burden of mental illness in the country is enormous, because people are not able to get to have the resilience, by having promotive mental health services. We are not able to prevent, risk factors which could lead to mental illness or even having an intervention. And so it's about saying that really work in the Ministry of Health, I have a big responsibility, and I know this is a responsibility I would call upon all Kenyans. We work together. Taskforce has given the report. And this is not the first time we are having a report on the status of mental health in the country. We have had a report by the Auditor General on this in 2017. 2011, we had a report by the Kenya National Commission on Human Rights. And I think it's a high time, and this has been well quoted within the policy. In 2016, we were able to come up with a policy, and we thought this policy would be the roadmap to shape on our way forward. What we need to do now that we know that the services are not there, there is a huge impact to the country, and this impact affects people across board, whether regardless of your race, economic status. So we really need to prioritize. One thing which has been seen as a major barrier, and it was identified even by studies and also even in the policy, was the issue of the stigma. The stigma around issues issues of mental illness affect not only the issues about leadership and governance around mental health, it affects around investment, it affects around prioritization. But I'm very happy of late that many Kenyans have come on board, that we are able to talk about issues about mental health and also mental illness. And we need to build on this momentum by bringing more people on board, by asking our leaders to give more resources and do this. What are we doing as a ministry? I think this task force came as big realization from the top of the leadership in this country. The president pronounced himself on this matter last year. We were able to prepare a lot of briefs to the cabinet and to the presidency around the situation of mental health and mental illness. And I'm looking forward now that this report is out, which has been part of the process of what the president was looking out for. We'll have implementation. Will the government manage to do everything? No. We'll need the private sector in this. We need the international implementing organization and donors to be part and parcel of this. We need the faith-based organization, the church, to participate, the community. So it will be a collective engagement to see that now that we know what are the issues, the Kenyans have said, the task force has put it together, the policy is there. How can we move forward? We move from the talk to action. Because if more than 85% of Kenyans can't access the services, then it means that when we are not mentally healthy, then we are not productive. And I think mental health is not just a health issue, it's also a socio-economic development issue. And it's also a human rights issue. And we think now the paperwork we have done from where I sit, we continue with advocacy from the user, the caregivers, and get the county government, health services are developed. We get the churches, we get the private sector, we get the people in the philanthropy to put the investment, to put the money, so that we start having the infrastructure put in place. We start having community-based mental health services being established. We have preventive and promotive programs, program to support people who have lived experience. Actually, one of our people with psychosocial and intellectual disability, one of the recommendations is that the government may provide incentives to people who put the investment to provide programs which take care of issues of mental health. Back to you, Chair. I think there are many things we need to do. There is the aspect of research. Research has to go hand in hand because we need to inform our investment with, there must be based on the best practices, on evidence. We must know how big is the burden, how big is the problem, and that's why we have recommended even a mental health survey, so that we know. I know one of the things when you go to the Ministry of Finance, will ask you is what is the unit cost and how much money do you need? I know all these, and we have worked around this to see how we can put our case forward, and we get Parliament, we get executive, all put the money around this. This is what we normally call the mental health disparities, that the inequality is so huge that some affirmative actions is required to bring things to equal to the other aspect of health. Back to you, Chair.
Okay, I'm reading some comments here. Anne Njoroge agrees with Melanie that we have many jobless counselors. Let's upskill and deploy them. Innocent Odiambo has a very interesting set of comments. One, he wants us to employ retired psychiatrists in Western Kenya. Probably a good idea, because they might also need to teach other people who are not retired. Innocent also makes the point, and I think it's a good point, that each county, health being devolved, each county needs to develop its own county-specific policy or approach. We actually went to Makueni during the work of the task force, and Makueni stood out because it has a very comprehensive mental health program. And if there's anybody in Kenya who would like to see a model of how county governments work in health, I would, without hesitation, suggest a visit to Makueni, because really they are doing extremely well there. Then I saw a question, and this goes to Charity. I'm sure they just want to hear Charity again, but I don't mind. I don't mind hearing Charity. Charity, the question is, to what extent were persons living with mental health challenges involved during the life of you answered that question already, but I'm sure they just want to hear you speaking again. Can you address it very briefly, Charity? To what extent with people with lived experience involved in this whole task force report? Charity, unmute yourself first.
Okay, thank you for that question. When the task force started advertising for public participation to happen, it's something that went around, the different mental health groups, and we encouraged people to participate within our own support groups. We called our people in Eldoret, in Mombasa, in different places, and some of them I'm seeing them right here who participated. I think Nairobi had the best participation, and because we're in the mental health circles, we know each other, we were all there. And apart from that, when we advocated to be included in the task force, we did it as a team. We came together and said, these are the things we want. We are very happy that the task force, provided a seat to actually be included in the task force itself. And like I said, we then sat together across the various conditions and had an opportunity to participate again in doing a presentation for ourselves. And even within the access to health chapter, which we are dealing with right now from page 50, you will find our contribution. So we have been included, we have been acknowledged, we have participated. Thank you.
A question. Oh, this is an easy one. I know the answer, so I'll answer it myself. It's coming from Machoka Penina. Machoka Penina is asking about screening services for persons with mental health needs. And she argues correctly, in my view, that just the way we ask people to check on their random sugars or blood pressure or whatever, tell them to exercise, why don't we get people to check on their mental health by screening them like we do for physical health? Indeed, this is one of the recommendations of the task force, that everybody who is in any position in our country, starting with teachers, with policemen, with priests, with imams, with any person. In fact, our recommendation here was that we prepare, or rather we cause to be prepared, a simple curriculum that can be internalized by everybody, so that there is a checklist that tells you that if you score this, that, or the other one, your mental health requires some measure of improvement. There's another very important point that was made, I think, by Professor Otwole in his presentation in this particular regard, which is the fact of self-care. We don't talk about self-care often enough in this pyramid. The truth is, not everybody should or can go to a psychiatrist or psychologist or any mental health worker. A lot of people will be able to self-care, just like not every person goes to a doctor every day. By doing straightforward health things, like you do exercising, avoiding too much alcohol, physical exercise regularly. Self-care is really the pillar that will support mental health in our country. And I think we, as the stakeholders, need to get more and more people to understand that singular point. Secondly, and again, I'm back on the pyramid, and I'd urge you who are here present on this webinar to look at that pyramid. The next level is informal community care. You don't have to see a qualified psychiatrist or even psychologist. Your priest is a good person, your imam is a good person, your uncle is even qualified to. And as long as they are armed with accurate information, we can help reduce the burden of on mental health specialists by doing self-care and working in informal communities. And then, of course, and this we have, the government has already done quite a lot of work, which is empowering primary healthcare workers. Those three groups or those three issues really would cover very well mental health issues for the majority of Kenya: self-care, informal community care, and primary health care. Dr. Juguna, do you want to make a comment?
Yeah, it's quite true what has been mentioned, even looking to earlier question on issues of mental health literacy. I think that's very important, and we need to bring the aspect of mental health literacy in the curriculum from all the way in primary school, in secondary and colleges, that people already understand what is mental well-being, understand what is mental illness, when should they seek for help, what should they do in terms of self-care, and when this knowledge is out there, when people have the knowledge, they have the skill, then they are able to understand what they need to do in terms of mitigating risk factors which may affect their mental health, how to build up their resilience, and also able to know how to pick out very early signs and symptoms of any mental health and well-being, and be able to do what is necessary, either at those different layers, either providing self-care, informal care, and these reduce the burden within the healthcare system. And probably it has been shown by evidence that care which is being provided at the community level is more person-centered, tend to be more recovery-oriented. And I think this is the way to go. And the pyramid of care and the optimal mix of services really emphasize that it's less costly to put investment at the primary health care rather than to wait people who may be having severe mental illness and putting a lot of resources and providing care at the apex. So I've also seen within the comments someone talk about the deinstitutionalization process which happened in other countries across the world is the way to go, that pushing services to the community. It requires investment. We need our county governments to put investment around that. And this is what now I need to comment about services. That when you talk about the services, we need to ask ourselves, is what types of services are we giving, where, and how do we give these services? And the aspect of about where is already very clear, that primary healthcare services is the way to go. We need to decentralize services. About what types of services, the emphasis should be on promotive, preventive services, rather than concentrating on the curative and rehabilitative services. And then how do we provide these services? They must be person-centered, they must be recovery-oriented, they must be of quality. And this goes now with the investment within the key pillars of health, that we need the human resource, you need to have the infrastructure, and this infrastructure need to be put more within the community. We need to have the medicines, we must have our financing mechanisms, and this is why now the issues of the universal health care and NHIF is very important. For a long time, I know we are already working on them, that they provide services for outpatient services, and also extending to community outreach services on how they cater for this, and also extending the care for treatment and rehabilitation. We know they have been providing 60,000 for one person per family. Already we had a discussion with them this week. We need to extend that to 135,000 per admissions, and this should cover about 4 admissions in a year. I think we're already in a negotiations to get something close to that. So basically, I think that's what I have to say. Mental health literacy is very paramount, And actually, mental health literacy would also be another way to address the issue of stigma. Then also very important that people with lived experience working within their peer support groups, working within with the healthcare system. We have seen this work very well with the area of substance use treatment and rehabilitation. That the peers are able to work with the people within the community, identify them. We have programs where like people are having overdose with heroin, that the peers can be able to save them from an overdose by being able to provide naloxone within the community. We actually provide them even with the syringes and needles in a packed setup that they can prevent an overdose of naloxone, because it's better to have the peer know how to save a life of an overdose of heroin. Yeah, so we need, like, especially in the time of crisis, the peer support groups work together with the other healthcare workers to be able to get people to service, be able to make sure that people get quality services. So yeah, I think that's what I have to say, Chair. Back to you.
Okay, now this I will let Charity. Do you have your slide on self-care, Charity? Can we? Charity wants to very briefly because Monica Kinyanjui is asking about precisely that point.
Okay. Let me request. It was on my slide. It was the last slide, but because of time, I didn't handle it. But we were basically saying that even our participants, we would want them to go home with something by saying, if you're able to take care of your physical health, sleep well for 8 hours at least, have a good diet, exercise, rest, have a good work-life balance. On the slide, we also had the spiritual, because we are spiritual beings, and whatever it is that you believe in, and you're able to find hope in times of, struggle, then it helps. There's also psychological, so being able to access therapy. It's the last slide just before thank you. Yes, there. So it's on the far left. So physical, sleep, stretching, walking, physical exercise, yoga for those who are comfortable with that, and resting, especially sleeping 6 hours. Emotional, manage your stress. Have emotional maturity. Forgiveness is very paramount in order to be able to, release unnecessary burden. Having compassion and kindness, even for us as persons with lived experience, when we support others, it contributes to our health. Socially, being able to have good boundaries to say no, support systems, positive social media, just listen to only as much as you need to, have time together as a family, ask for help is a very key one, and especially for our men. Then spiritually, like we said, meditate, have time with nature, journal your feelings so that you're able to have an outlet. And then support groups, which Dr. Njuguna has talked about. Like right now, we have an online support group every 2 weeks. When things were okay, we had it every month, but now we have it every 2 weeks. Most of us are not even able to afford the bundles, so we start as a WhatsApp group for 2 hours. So we send a link, we enter a WhatsApp group, we say it is called Vegas, and what happens in Vegas stays in Vegas, and we're able to debrief and talk and support each other. Then lastly, we're very happy that the Ministry of Health advertised the 1199 for support in counseling, which is by the Ministry of Health and Kenya Red Cross. So when you do need to talk to someone, please call 1199. It is toll free and it is 24 hours a day. Thank you.
Thank you so much. I really must bring this exciting webinar to a close. I think we have all learned a lot this afternoon, but most importantly, I think what Charity has ended up saying is that we are not helpless bystanders in this whole mental health process, because there's a lot we can do for and by ourselves in the promotion of our own mental health. I am sure that all this material will be available at the end of this presentation. This webinar has been recorded, and I think will continue to be available. And I thank you very much. Now, let me thank, first of all, Dr. Njuguna, Priscilla and Maureen in the Secretariat for having put this webinar together. Professor Atwoli for having sent in your presentation, Melanie Blake for your very, very useful presentation that was well received, and finally, Charity for being an absolute star in conveying the message that required. Until next time, ladies and gentlemen, thank you for your time. Thank you very much. The report is available, and I saw Priscilla sending a link to where this report is. I thank you all. Have a wonderful evening until we see you again in the future. Kwaherini ya kuonana, asanteni. Bye-bye.